Welcome and thank you for joining us for Ask Me, our educational webinar series. My name is Steve Goklowski, Vice President of Care Services for the ALS Network. I want to thank our presenting sponsor, ALS News Today, and our accessibility and inclusivity sponsor, Shionogi, as well as our mission benefactor families and everyone who helps support our programming. Programming like this one, as well as the services we provide, are made possible through the generous donations. And now I want to share with you a brief message from our presenting sponsor, ALS News Today.
Hi, my name is Juliette Taylor, and I'm a columnist for ALS News Today. I lost my husband Jeff to ALS in May of 2020, just 19 months after his diagnosis. One of the most important things in living with a disease like ALS is access to information, resources, and support. That's why ALS News Today is so proud to co-sponsor the 2026 Ask Me webinar series put on by ALS Network.
Now and always, we want to ensure that you know that the ALS Network offers a menu of services free of charge to people with ALS and their families. Please know that if you need a piece of equipment loaned to you, emotional support or counseling, assistance with finding home care, help understanding insurance benefits, guidance in finding an ALS specialist for care or clinical trial, or just someone with expertise to answer any questions about the disease, the ALS Network is here for you. Our committed staff, who are locally based in California and Hawaii, provide high quality, personalized, and local services, as we also fight on the legislative front and build our growing research program. We are your local team, and we are glad to provide multi-layered support. To learn more about the ALS Network and programs and the services we provide, please visit www.alsnetwork.org for more information. Today's program explores key aspects of palliative care and support for individuals living with ALS and their families. Dr. Kara Bischoff is a professor, the Associate Division Chief for Outpatient Palliative Care, and the Medical Director of the Outpatient Palliative Care Service at the University of California, San Francisco. Dr. Bischoff has developed a particular expertise in palliative care for people with amyotrophic lateral sclerosis, ALS. She launched and co-chairs a national palliative care for ALS working group housed within the International Neuropalliative Care Society. She has published substantially about outpatient palliative care for people with ALS and other non-cancer serious illnesses. In 2024, she was recognized as an emerging leader in palliative medicine by the American Association of Hospice and Palliative Medicine. Dr. Bischoff received her medical degree from Harvard Medical School, followed by a residency and chief residency at UCSF in internal medicine and a fellowship in hospice and palliative medicine, also at UCSF. She's a mother of two, an outdoor enthusiast, and a San Francisco Bay Area native. Thank you for being here, Dr. Bischoff. Please take it away.
Thank you so much, Steve, for that very kind introduction. I'm going to share my slides and start the slideshow. It is such a pleasure and a privilege to be with all of you this evening. Thank you for coming and for dedicating some of your time to learn about palliative care. My talk is entitled Living Fully, Living Well, and I hope that I'll help to describe a little bit about how palliative care can help with that. I also wanted to acknowledge one of my close colleagues, Ambreen Mehta at Hopkins, who helped put together this talk, as well as our Palliative Care for ALS working group, many members of which have contributed to this work. As a matter of disclosures, I do want to acknowledge that I'm a palliative care physician, so I come with that set of biases, and I've received grant funding from the ALS Association to study palliative care for people with ALS. So what is palliative care? In one short phrase, I would say it is care focused on improving quality of life for people living with a serious illness. And I want to emphasize that palliative care can be provided alongside life-prolonging treatments like ALS medications at any stage of a serious illness. And when I describe palliative care a little further, I often describe that it has three sort of buckets of what we do. First, we focus on symptom management. We help to manage any symptoms that are difficult or refractory, such as pain, excess saliva, difficulty with sleep, constipation, as well as mood symptoms like depression or anxiety. The second bucket is that we help people with an illness and their families understand the illness, get their questions answered, and plan for the future. Third, we offer psychosocial, spiritual, just general support to both people living with the illness and their loved ones. Palliative care was started, sorry, hopefully my slides will advance, by Dame Cicely Saunders in the United Kingdom. And she had this concept that people living with a serious illness often have total pain, or I might call it suffering, with contributors from physical symptoms as well as from psychological symptoms, social needs, and spiritual needs. So, really, palliative care strives to support people in all of these domains: physical, psychological, social or practical, and existential. Dame Cicely Saunders famously said, "You matter because you are you, and you matter to the end of your life. We will do all we can, not only to help you die peacefully, but also to live well until you die." And we really try to support people, see them as whole people, and help them live as well as possible in the face of a serious illness. So to say a little bit more about palliative care, this is very much multidisciplinary team care. It's typically provided by a doctor or nurse practitioner alongside a nurse and a social worker and or spiritual care provider. So there's people who are addressing the medical needs, the psychosocial or spiritual needs, and in care coordination. There's dedicated attention to symptoms, and I realize that many ALS teams also focus on symptoms, but sometimes when symptoms are severe or refractory or numerous or progressing quickly, it can be helpful to have that added bandwidth to spend a little bit more time and energy focused on managing symptoms well. There's also additional time and staffing for supportive counseling for people with the illness or their loved ones. People in palliative care are trained in serious illness communication, can help with difficult conversation about what's to come so that that doesn't have to all be the responsibility of the person with the illness or their family to navigate alone. They can help with care coordination and navigating our nutty healthcare system and assist with transitioning to end-of-life care. Many people ask me, so how is palliative care different than ALS care? And maybe you might be attending a multidisciplinary ALS clinic with many clinicians already involved in your care. So just to summarize this in a slide, in the ALS clinic, people typically receive a diagnosis, receive education about their illness. The ALS team may offer genetic testing. They may help to explore risk factors for the illness. They track the illness over time. They offer disease-modifying treatments that may include medications as well as equipment. They also address symptoms, sometimes pain or difficulty with sleep, constipation, depression, anxiety, and offer support and connection to community resources. Now, palliative care, you'll see, has some overlap. So certainly there's a big focus on managing physical and mood symptoms. So that's not altogether different from what the ALS team is doing, but certainly the palliative care team can add bandwidth in that area. They also add bandwidth in terms of emotional support and encouraging healthy adaptation to the incredibly difficult set of changes that are dealt by ALS. They can help people really think about their values and priorities and prepare for the future with this illness when that's of interest. They offer additional time and space above and beyond the ALS clinic visits to consider treatment options, for example, about a PEG tube or a tracheostomy when that feels really difficult and you need extra time to think that through. They also add extra bandwidth to support family members or caregivers, and they can talk to people about options like hospice and other end-of-life care when the time comes. So how do you get palliative care? You can ask any doctor for a referral to palliative care. Palliative care is a medical specialty, just like cardiology and neurology. So it does require a referral in order for insurance to cover the care, but you can request that from your primary care doctor or your ALS doctor. It is like other medical specialties, typically covered by insurance with a small copay. So many people have a $20 copay like they would to any other medical specialist. Palliative care can be delivered in a clinic. Sometimes it's embedded within the multidisciplinary ALS clinic. Other times it's in a freestanding clinic. And it also can be provided at home. Sometimes palliative care is provided by a home health team that has an expanded services in that area. And increasingly, palliative care is being provided by video, especially to people with ALS when traveling to the clinic can be difficult. And the visit frequency for palliative care typically matches one's needs. So it might start off with monthly visits, for example, and those visits could either ramp up if needs accelerate or could be spaced out. So I'm not going to go into all the science and data we have about the benefits of palliative care for people with ALS, but I'm going to briefly summarize just a few trials. So there was a trial about palliative care for people with neurologic illnesses, including ALS, that showed an improvement in pain, shortness of breath, bowel symptoms like constipation, sleep, and quality of life with palliative care. And that was published by a group in Italy. And then there was a trial of palliative care for people with neurologic illnesses, again, that included ALS. This was done in the UK, and it showed improved symptoms and satisfaction with care when people received palliative care compared to usual neurologic care alone. We did a cohort study at UCSF showing that palliative care, when integrated into ALS care, can help with needs in multiple domains, including physical symptoms, psychosocial and spiritual concerns, help people plan for the future and complete advanced care planning documents, and help with care partner needs. And with palliative care, we showed that the rates of advanced care planning increased and hospice use was common. There are two other groups in the US, the group led by Kate Breezy at Mass General and the group led by my colleague Ambreen Mehta, and she worked with another researcher at UCLA, showed that integrating a palliative care physician into the ALS clinic can help with physical and mood symptoms and support care decisions. And finally, there was a recent cohort study from Washington University that showed that palliative care, when integrated into ALS care, was associated with more goals of care conversation, more identification of healthcare proxies, like clarifying who people wanted to make decisions about their care, and more hospice use. So you can see from a variety of studies that palliative care has been shown to help with symptoms, to help with preparing for the future, and to offer support to both people with the illness and their loved ones. So I'm going to try to bring this to life a little bit with a case. So one of my patients was a 61-year-old man living in a rural area in the far reaches of Northern California. He was a complete outdoorsman and an avid river kayaker. He was also a loving husband, and he had a son with advanced autism who he and his wife were very busy taking care of. And he developed progressive weakness since June of 2024, led to a progressive functional decline where he initially wasn't able to hike and kayak as much as he was prior. Then he got to the point where he couldn't even walk as comfortably or quickly as he could prior, and he had progressive fatigue. He then went on to develop slurred speech, and it was after that symptom developed that he was ultimately diagnosed with limb onset ALS in October of 2025, a full 16 months after the onset of his symptoms. He immediately was concerned about how his illness would impact his family as he progressed through the stages, particularly given his son's substantial needs. And soon thereafter, in December of 2025, he developed shortness of breath, particularly when lying down, as well as when trying to exert himself. At that point, he was referred to palliative care for help with his symptoms, including his shortness of breath, to offer support to his wife, which was of great concern to the patient, and to help them prepare for the future. So palliative care can make a lot of sense for folks like that because there is a high symptom burden in this illness. There are substantial caregiving needs. There's this inexorable stepwise decline in the illness that is very difficult, challenges people to adapt time after and time again to these unwelcome changes. There's really complex decision making that people face, concerns about the future, and difficulty with communication makes it all the more challenging. And of course, I'm not saying anything you don't know. But the goal is that with palliative care, we can help at least a little bit to alleviate symptoms and improve comfort, to enhance emotional and psychological well being in the face of this very difficult disease, and to facilitate communication and decision making in advance of an emergency, and finally, support patients and really the whole family throughout the journey. I'm going to pause briefly for an interactive segment. So if you could write in the chat, is this a truth or a myth? People must stop seeing their ALS team if they are receiving palliative care. What do you think? Truth, myth, or unsure? And if you write that into the chat, my faithful team here is going to share what they see in the chat.
Yeah. Well, right out of the gate, Cara,
Yeah.
myth is the popular answer. So I
Great.
think I
Fantastic.
don't see anybody saying it's the truth.
Okay, thanks so much. Okay, so you're with me from that first slide when I shared that palliative care can be provided alongside other disease-modifying treatments, including ALS care. Yes, that's exactly right. One more for you. People cannot continue ALS treatments when receiving palliative care. Is this true, a myth, or you're not sure? People cannot continue ALS treatments when receiving palliative care.
Okay, the answers are coming up myth. So
Great.
they're also saying it's a myth.
That is also a myth. So excellent. Thank you so much. No one's tricked by any of these myths. And just to share a little bit more about this, this was sort of the old model of care. We used to think of it as people would receive disease-directed care, in this case, ALS care for the majority of their illness, and then palliative care would come in and ramp up at very late stages of the illness, and people might transition to hospice care. But more recently, we really see this model very differently. People should receive disease-directed care alongside palliative care from the time of diagnosis. And palliative care may ramp up over time as the illness progresses, but really having both types of care available to you from the time of diagnosis is often helpful. And then people can transition to hospice and hopefully receive bereavement care as well. So coming back to our patient, Mr. JL, so he was referred to palliative care, and I should mention that he was also started on non-invasive ventilation around that time because of the shortness of breath that he had. So I would very much support that, and I often talk to people about non-invasive ventilation or communicate with their ALS team about the need for that if that hasn't already been started in a situation like this. But we also started him on low dose morphine, which you might think of as a medicine for pain, but also at very low doses can be helpful for shortness of breath. And our spiritual care provider actually talked with him about mindfulness strategies for managing those episodes of shortness of breath when they occur and trying to stay calm to avoid a loop of anxiety sort of getting superimposed on the shortness of breath and making things harder. Our social worker and spiritual care provider also provided a lot of emotional support, both to Mr. JL and to his family. And I started him on a medication, SSRI, for anxiety, given the intensity of the feelings and worries he was having. Our social worker also met with him and his wife to talk about some practical concerns they had about how they can set things up, how they can hire help when needed, etc. And Mr. JL was really interested in thinking about the future from even our first visit. And I find that that's common in ALS. So advanced care planning in ALS really starts from the first visit. And it starts with trying to understand people's values and priorities, broadly speaking. A couple of the questions that we often ask are, as you look to the future, what are you hoping for? And what are you worried about? Just understanding what people are hoping for and what they're worried about can often help us provide them with practical information, sometimes reassurance, sometimes help them plan and prepare to make things go as much the way they want them to as possible within the confines of the illness. We also ask people commonly, if you weren't able to make or communicate your own healthcare decisions, is there someone who you would trust to speak on your behalf? This is really getting at the question of a durable power of attorney for healthcare, or also known as a surrogate decision maker. And I think it's worth just mentioning that if no one is named and documented, decisions are deferred to a default surrogate. So many states have a hierarchy where if you can't speak for yourself, decisions will be made by a spouse, or if that person isn't able to make decisions for you, then an adult child. And you can proceed down the hierarchy. In the state of California, we actually don't have a legal hierarchy, so it's up to the clinicians who are caring for a person at that time to try to figure out who are the people who are able to, who understand this person's values and priorities and are best able to make decisions for them. This may work out okay if you do want your spouse to make decisions for you and they are, by your side often, but for some people, that's not who they want to make medical decisions for them. And so I think this is an important question to ask and clarify. And one's preferences about their future care, as well as about their durable power of attorney for healthcare, can be documented in an advance directive. This is a legal document. And it can be completed and is often completed by our team. It doesn't have to be completed by an attorney. And it also can be updated by a member of the healthcare team at any time, or by you at any time. I also wanted to share, 5 wishes is one document that many people use. But there's also an interactive website called Prepare for Your Care that I think is really great and steps people through all the different considerations regarding advanced care planning, though it's not specific to people with ALS. But it has a lot of interactive videos and really explains what all these different terms refer to, so it can be helpful. And at the end of the website, it pops out an advance directive that you can print out, and it's legally valid. There is also an ALS values assessment guide, which is essentially an advanced directive that was developed specifically for people with ALS. And I would mention that it's quite lengthy and detailed. So it is a nice option if you're someone who really wants to prepare, be as prepared as possible, plan ahead, think through all of the considerations that are likely to come up. But I would also say that it can be overwhelming for many people. So to be honest, we often pick pieces from this or questions and themes and talk to people about it during our visits as the illness progresses. Another aspect of advanced care planning that we commonly engage in with people is making sure they have the information they want and need about any treatment options that they're facing. For example, about a feeding tube, about types of ventilatory support, whether that's a non-invasive ventilator or a tracheostomy for invasive ventilation. We might talk to them about resuscitation preferences at later stages of the illness, or whether they would like to go back to the hospital if they have an issue that arises. And we try to make recommendations to people that are grounded in their values and priorities and allow additional time to sort of explore all options, realizing that you might have heard of these things. A feeding tube might have been recommended by a member of the ALS team, but sometimes it's worth just really unpacking that decision and having a little extra time to explore one's options. We also, as I mentioned, talk to people about whether and when a transition to hospice might make sense. So to say a little bit more about hospice care in ALS, first of all, I want to explain what hospice is. It's essentially a program and a Medicare insurance benefit, and it is appropriate for people with a prognosis of 6 months or less. One has to have a prognosis of 6 months or less in order to qualify for hospice. And hospice care is focused on providing comfort, but not life-prolonging treatment. So those are two important differences between palliative care and hospice care. First, that hospice care is only for people with a prognosis of less than 6 months, whereas palliative care can be appropriate at any stage of a serious illness. And in hospice, there's a focus on comfort, but life-prolonging treatments cannot be provided, whereas in palliative care, you can receive life-prolonging treatments like ALS medications or a clinical trial alongside comfort-focused treatments. So when is it time for hospice? Many people with ALS ask us that question. To tell you a little bit about the criteria, and if one has advanced respiratory weakness, a forced vital capacity of less than 30%, or significant weight loss, more than 10% weight loss in the past 6 months, or other potentially life-threatening complications like a hospital admission for an aspiration event or pneumonia, or another severe infection like sepsis, and a person wants to focus primarily on comfort and stay in place where they are, which is typically at home, and not go back to the hospital, then it may be an appropriate time for hospice. So, quick truth or myth to make sure you're still with me. People cannot continue ALS medications in hospice. Is this a truth, myth, or unsure? People cannot continue ALS medications in hospice.
So I'm getting a mix. Some are saying true, some are saying myth. It's kind of
Okay.
a mix now.
Thank you, Steve. So, in general, this is true. People generally cannot continue their ALS medications or other life-prolonging treatments on hospice. There may be occasional exceptions made, but in general, that's the case. And it's also true of other illnesses. So, people with cancer can't continue their cancer-directed treatments like chemotherapy when they go to hospice, because hospice care per Medicare requirements is focused purely on comfort, not life prolongation. So, what to expect with hospice? Certainly, you can expect attentive symptom management. The hospice team is really, like the palliative care team, quite focused on managing symptoms and helping people be as comfortable as possible. The hospice team can also often help people get easier access to medications, medical supplies, and some types of equipment like a hospital bed or oxygen, for example, although that's not often needed in ALS. The hospice team also can make home visits. Um, the hospice nurse will visit every week or two and can visit more often if needed. They also have an on-call team 24/7 so that if something happens after hours, maybe there's a fall or a question about shortness of breath or pain or another symptom, you can call and get help from a nurse even after hours, which is a significant advantage. Sometimes the hospice team will continue tube feeds and a form of non-invasive ventilation called BiPAP, which is a sort of lower level of respiratory support for people with ALS. These are not commonly provided to other people on hospice, but because many people with ALS need tube feeds or some respiratory support in order to be comfortable, they can be provided on hospice. They certainly provide care partner support with more touch points at home, and the hospice benefit includes grief or bereavement support for up to a year after the death of a person. But what one can't expect with hospice is 24-hour care at the bedside. The hospice team just makes discrete visits. The nurse might come out for an hour or so every week or 2 weeks. There might be a hospice social worker who makes a visit for an hour once a week for supportive counseling. But there's no member of the hospice team that comes out and spends all day, every day, providing care at home. So I think that's a common misconception. And so I want to emphasize that. Also, typically medications for ALS aimed at prolonging life cannot be continued while on hospice. Maybe an exception for Ronusol since it's old and cheap, but not possible with Radicava, for example. They also don't provide do blood work or imaging. They're not focused on diagnosing new issues. Like if there was a fever, for example, they would treat someone symptomatically, but they wouldn't work it up with blood work and imaging. So it is a bit of a shift in focus and in the way that care is provided. They also don't typically provide rehabilitation services like physical therapy, occupational therapy, respiratory therapy, unfortunately. They also can't provide certain types of expensive and specialized equipment like new power wheelchairs or speech generating devices or non-invasive ventilators with higher settings like a Trilogy machine. Because, just to be totally honest with you, hospice has a limited budget. They get about $200 a day. They are not able to cover some of the really expensive specialized equipment. And they generally don't provide hospital care. They try to care for people at home or wherever they are living and call home, except when symptoms can't be controlled in that setting. So, truth or myth, most people move into a hospice facility when they enroll in hospice.
Okay, let's see. So far, we got mostly myth.
That's right.
Not
That's right. So I think there is this common myth out there that hospice is a place you go. But no, in fact, most hospice care is provided at home or wherever you call home. Sometimes people are living in a facility, um, a long-term care facility, for example. But usually people are kept in place and they don't transition to a new facility for hospice care. However, if for whatever reason care can't be provided at home, there are a few residential hospice facilities, but they're pretty few and far between and often aren't honestly the best place to accommodate ALS care given the specialized needs. And then a brief slide about medical aid in dying. I actually wasn't planning to include this in this talk, but I got a number of questions about this in the questions that were submitted in advance of this talk, so I wanted to cover this. So medical aid in dying is legal in a growing number of states. We're up to 10 states and the jurisdiction of Washington, D.C., where medical aid in dying is legal. Overall, in all these states, the requirements for medical aid in dying include that you have to be an adult resident of the state with a terminal illness and a prognosis of less than 6 months, as determined by at least two doctors. One has to be of sound mind and able to make decisions for themselves at the time when their prognosis is less than 6 months. And they have to have the ability to self-administer the end-of-life medications. So to take them themselves, either by mouth, via a feeding tube, or if one can't swallow and doesn't have a feeding tube, a rectal tube can be placed for this reason. And people with ALS actually are the population with the highest rate of requests for medical aid in dying compared to all serious illnesses. So there was a case series in Oregon and Washington that found that about 5% of people with ALS in those states end their lives using medical aid in dying. And this was much higher than the rate that people used medical aid in dying who had cancer. That was only 0.6%. And only 0.2% of all people who died used medical aid in dying. So again, it's an issue that comes up much more often in people with ALS than other illnesses. And I also want to acknowledge the complexity here that many people with ALS worry about losing their ability to self-administer end-of-life medications at the time when their prognosis is less than 6 months and they feel ready to proceed. So sometimes we do have to talk to people who feel strongly about having this option and ending their lives on their own terms. We have to help them understand, when they enter this window where their prognosis is less than 6 months, assuming that they still maintain mental capacity to make this choice and are still able to self-administer the medicines. But I also want to acknowledge for those who don't live in a state where medical aid in dying is legal, or are not interested in medical aid in dying or are not eligible for it, there are a lot of alternatives and other ways that people end their lives in the setting of ALS. For example, many people with ALS get to a point where they decide not to continue their ventilatory support, the non-invasive ventilator, for example, and instead use medications for comfort while tapering gradually off that support. And some people pursue voluntary stopping of eating and drinking, which I want to just briefly mention can be a difficult process. So it's not something that is commonly pursued. Before we conclude, I wanted to leave you with a few resources that I've actually been working actively recently to develop. So with the ALS Association team, I developed a new website about palliative care for people with ALS that's on the ALS Association webpage. There's also a national directory of palliative care programs that have particular experience caring for people with ALS that we created, and that you can link to that through the ALS Association Palliative Care for ALS page. You can see it right here is the palliative care directory, and you can put in your state, or other details about your area and find palliative care programs, again, with experience in ALS in your area. There's also the Palliative Care for ALS resource guide. This was put together by my colleague Ambreen Mehta, and it's essentially an online site where it links to all the different resources about palliative care for ALS, hospice care, advanced care planning, and end-of-life care. So you can find a lot of the high quality resources that are available on the web all in one place and searchable. Each of these they have hyperlinks, by the way, so we'll make sure this is shared so that you have access to these websites. I also wanted to share a blog post that gives a little bit more of a personal report about what palliative care was like. And I wanted to share the International Neuropalliative Care Society's website. As I mentioned early on, and Steve mentioned in my introduction, I've started a National Palliative Care for ALS working group that includes ALS and palliative care clinicians, researchers, members of advocacy organizations, people with the illness, and care partners. And we're all working together to try to think about what can we do to improve palliative care for ALS and make it more available to those who need it. To tell you a little bit about what we've been doing through the working group, I'll make this brief though. Our goal really is to improve the quality and access to palliative care for people with ALS. We have strengthened our collaboration and coordination across the country through this Palliative Care for ALS working group. We are working on clinician education, so educating ALS clinicians about palliative care and hospice, also educating hospice and palliative care clinicians about ALS. We have a lot to learn. I've been presenting at a number of national meetings about that, trying to improve public awareness. So doing some webinars, including this one for people living with the illness and their loved ones, the websites that I just described that provide some information about palliative care for ALS. We're also developing resources, for example, the Palliative Care for ALS resource website that I just shared, the Palliative Care for ALS directory, which helps people, both clinicians and people with the illness, find palliative care services that are appropriate for them. And we're developing some tools to screen for palliative care needs in ALS clinics more routinely. We're also working on clinical service expansion, so trying to develop the skills of palliative medicine and hospice providers. They can provide better care to people with ALS, providing mentorship so that more people can go into this area, and helping to develop more such clinical programs. And then actually a big bucket is about our research. We're trying to do a multi-center randomized controlled trial of palliative care co-management for people with ALS, like looking at what is impacted when we integrate palliative care into ALS care. I know I showed you a number of trials along those lines, but those were all single center, and we're really interested in doing something very robust to generate high quality evidence. We're also looking at how we can best screen for palliative care needs and identify people who are appropriate for palliative care more consistently. And we're doing research into symptom management in ALS. How can we better manage these very difficult symptoms that people with ALS face? So I'll end there, and I want to thank you again for your attention and leave plenty of time for questions.
Great. Thank you so much, Cara. All right. So we have a number of questions. Some of them, I think, as I've been watching them come in, you've sort of answered within the context of your presentation, but I'll revisit them anyway, just in case there's something more you want to speak to with them. And I'll just go straight down. We have a number of them, but not too many. One of them says, how I'm empathetic to this person. I can feel their frustration. How to make palliative care to a PALS who's already fed up with ALS medical care in general. I think they're weighing a decision with what they're going through.
Absolutely. And, you know, it's not uncommon that we hear that people are very frustrated by their multidisciplinary ALS care, that sometimes it's exhausting to go to those visits. There's a feeling of it can be discouraging to sort of have the course of your illness tracked, but not a lot of solutions to make things better. And I absolutely feel that, you know, our medical system is just incredibly difficult to navigate. And so there's a lot of challenges and understandable frustrations in the people that I see, and I'm sure that you experience. And in palliative care, we're trying to bring the humanity back into medicine just a bit, trying to spend a little bit more time trying to understand who people are as people before their illness, and with their illness, what matters most to them. What are they hoping for? Where are the moments of joy in their days? How can we help to support these, their hopes and their moments of joy amidst all that is hard? Or how can we chip away at what's hard and the practical challenges make things just a bit easier? Can we help with care coordination or communication or getting them answers to their questions? Can we, talk to them about their experience and just make sure they have an opportunity to be heard and understood? So we are a bit countercultural in palliative care and kind of um honestly, one of the reasons I went into palliative care was in reaction to what I saw as a somewhat inhumane medical system, and particularly when my dad had dementia during my medical training and realizing how much falls on families and how in how many ways the medical system doesn't really help support, whole people and whole families. So um, I can definitely sympathize with this, and I think palliative care does try to help fill in some of these gaps, although I can't claim that we can do it all.
Yeah, thank you.
Yeah.
I think you addressed this one when you were describing a little bit about contrasting what palliative care is as compared to hospice. The question said, how do you explain palliative care benefits to clients when often palliative care is perceived as end of life or hospice?
Yes. So you're right. That's very common that people conflate the two. That was partially why I really hammered on those points in this presentation. Sorry if it was too repetitive, but trying to emphasize that palliative care tries to help people live well in the face of a serious illness, or tries to help improve quality of life in the face of a serious illness, and can be appropriate from the time of diagnosis and alongside other treatments throughout the disease course. So it's very different than hospice, which is end of life care appropriate for people with a prognosis of 6 months or less who
Mhm.
prefer to focus exclusively on comfort. Um, so we try to explain that. We try to explain that we see many people over years, and that we see many people from the time of diagnosis, but I'm sure plenty of stigma remains.
Yeah. The next one says, since you've done some research and some publications, have you studied the value of palliative care in helping clients feel hope in the face of a terminal illness, and how is that approached?
Yes, yes. Such an interesting issue. I think ALS, as much as any other illness I can think of, challenges people with a lot of different changes over time. Just a lot of really difficult, significant, usually unwanted changes. And so, how to help people maintain some hope, I think sometimes we have to evolve what our hope looks like. Initially, hope might be, I'm going to beat this thing, I'm going to be cured, I'm going to be one of the reversal cases. And if that doesn't become the case, then people might hope to slow down the progression. And we try to help people expand their concept of hope. It might also include, I hope to be able to spend more meaningful time with my children or grandchildren. I hope to be able to make it to that family reunion or get to Hawaii for that vacation or whatever it is. So trying to expand our concepts of what we can hope for. And then it may evolve over time to, I'm hoping to be comfortable. I'm hoping that my loved ones know that I love them or have some support. Um, and so I do think that we talk to people a lot about what matters most to them and how can we make some of this still possible in the face of, a lot else that isn't possible.
Yeah, thank you.
Yeah.
Thank you. This is probably a little more of a medical question, is how to avoid pneumonia.
Yeah. Yeah. So pneumonia and infection in the lungs forms often in ALS when people swallow saliva that's, not sterile. It has bacteria down into the lungs. And so one of the most important things to do is to be careful and vigilant with swallowing. Sometimes that involves altering the texture of your food to have softer food, moist foods, foods that are easier to swallow. Learning techniques for swallowing might involve sitting up straight, being really mindful and careful, chin tuck. Um, Also having ways to clear your lungs. So using a cough assist device, for example, or a suction device when you're not able to generate a forceful cough and clear your lungs. Um, so those are some of the things. Also, of course, early detection. And I think another way that palliative care is really helpful is by being available and responsive to people in their times of need. I didn't probably say that enough, but I do think that that's actually what people mention to me most about what they really appreciate about the service is I can call you guys when, let's say, my loved one is having trouble breathing, did aspirate something, have, food go down into the lungs, and it's scary, and I'm trying to figure out what to do. And having someone to call who's going to respond to me is really meaningful, so that we might start antibiotics quickly at the first sign of an infection, for example. Yeah.
Thank you. This one, I think you answered implicitly when you talked about expanding our understanding of hospice as not being a place you go to, but as a service and a support that's received. Because this person asked, can I accompany my husband in hospice?
Right, right. Yeah, so most hospice is provided at home, and most hospice care is honestly provided by the family and with the support of the hospice team, but the direct hands-on care is typically provided by informal caregivers, loved ones, sometimes with some hired help to supplement, but yes, it's very much a family experience, and the hospice team is explicitly there to support the whole family.
Mhm. Right, right. One person was in regards to hospice and devices and so forth, said that one slide indicated that speech generating devices are not to be expected after hospital admission. Does that mean that a patient already who uses such a device that it needs to be forfeited before hospice admission?
Thank you for asking. I should have been more clear that if you have a power wheelchair or a speech generating device, typically you can keep these while on hospice, but new power wheelchairs or new speech generating devices typically aren't provided by insurance when you're on hospice. But the ALS network and ALS Association, for example, do have loan closets and may be able to provide a speech generating device, for example, if you're on hospice and then develop a need for that. So that's an option that we always encourage people to explore. We don't want to delay a hospice admission if someone otherwise wants and needs it to, get that power wheelchair in 90 days or something like that. So sometimes we do try to we reach out to the ALS network and see if something can be provided through a loan closet, so that someone's hospice admission isn't delayed if they otherwise need the service.
Okay, thank you. Probably this one was toward the bottom of the list and probably should have grabbed it when you addressed pneumonia, because this person said, what's the first sign of pneumonia?
Yeah. Yeah. So there's a variety of answers to that. But oftentimes it's shortness of breath and cough. Sometimes it's increased sputum.
Mhm.
Yeah.
Right. Okay.
Yeah.
I just want to encourage everybody who's attending the webinar. If you have a few more questions, we have a little more time. Please feel free to put those into the Q&A box. In the meantime, there's one here that is what I would say a very spiritual and existential question. And I
Mhm.
imagine that is something that palliative care people interact with and deal with often. Although I know, Cara, you weren't here to be a theologian today. But it's a part of people's lives. So this question was, and I'll just read it literally as it was put, is God part of palliative care? Have you ever seen God revive a person in palliative care?
Hmm. Thanks for asking. Yeah, I'm not a theologian, but so I guess it depends on your perception of God, and your definition of God. Um, but I think spiritual care is definitely a component of palliative care, and the spiritual care provider that I have the privilege of working closely with, every Tuesday morning when we're in the ALS clinic, provides a lot of really important support to people. And for many people, she's the most important person they meet with. They can talk about their perceptions of God, how God feels like they are or are not showing up for them at this time and in the face of their illness, and what they can do to grow closer to God in the face of their illness. And I think that's incredibly important. So I guess I'm evading the question because I think it might be different for different people. But I do think that these are really important topics that we explore with individuals in palliative care.
Yeah. No, I appreciate that. I think one of the things that I appreciate about palliative care providers and teams that I've met is the fact that they often include a chaplain or somebody who's helping to address those spiritual and deeper and philosophical questions, and to provide people an opportunity to explore that if that's something that really matters to them. So I
Mhm.
appreciate that very holistic and comprehensive approach.
Mhm.
Um, there was one new question. It says, aren't there a few live-in hospice care facilities?
Yes, there actually are. Here in the San Francisco Bay Area, there's one in San Francisco, has something like 10 or 12 beds and rooms. And then there's one in Redwood City, which is on the peninsula, within an hour of San Francisco. There's one in the East Bay, actually, also within an hour of San Francisco. So there are a few inpatient hospice beds. They're just not common and easy to come by. Often they're not available exactly when you want them, um, but rather have wait lists. So there are such facilities, yes, but the vast majority of people who use hospice services stay at home. And certainly that's true for people with ALS because many people in these hospice facilities, like many other facilities, aren't used to caring for many people with ALS and, may not be adept at giving tube feeds or putting on a non-invasive ventilator for support. Um, so sometimes things honestly go most smoothly at home.
Mhm. Great, thank you. All right, new question come in. I have respiratory onset. I was doing well with auxiliary muscle support, but now my atrophy and weakness is increasing in shoulders, lumbar, and limbs. Any ways to keep activity up as I feel this helps me breathe? As I become less active, my breathing with auxiliary muscles declines.
Yes, yes. So thank you for mentioning that because I didn't talk about physical activity in ALS, but that is something that has been shown to be helpful, and increasing research base is coming out to demonstrate that. I think um, historically, people used to worry that too much exercise might make ALS symptoms and weakness worse. But increasingly, we're realizing that moderate exercise can actually be helpful in allowing people to preserve function, quality of life, and energy. So, what's been studied is a combination of cardiovascular and strength training. Um, and I realize that's big. Basically, we don't really know exactly what exercise program is best, but there are physical therapists and occupational therapists on the ALS team that often advise people. There's also respiratory therapists. So for a person with respiratory onset ALS, um, they might be the most important person in sort of advising them about exercises to maintain their, chest wall strength and respiratory auxiliary muscle strength. And then in palliative care, we often refer to home health agencies as well for physical therapy, occupational therapy, and sometimes we're able to get respiratory therapy at home. Um, so a lot of breathing exercises. I'm not sure we know exactly which one is best, but it is true, even in ALS, you want to use it to try to not lose it for
Right.
as long as possible. So thank you
Sure.
for bringing that up.
Yeah, thank you. Okay, we have time for just a couple more, which have rolled in. Is ultra high dose B12 allowed in palliative care?
Yes, absolutely. Many of our patients are on high dose B12, and the UCSF ALS clinic does frequently recommend it along with riluzole and radicava, and sometimes um, other experimental treatments. But yes, it is
Mhm.
definitely something that an increasing number of people are trying, and I hope we have more evidence in the coming months to years to show the benefits of it.
Mhm. Okay. One says, can I keep my BiPAP ventilator once I move into hospice? I sleep all night with it.
Yeah. So most of the time, hospice agencies will continue BiPAP, and oftentimes they won't continue a higher level of support, fancier ventilators like a Trilogy device. There may be rare exceptions that can be made by a unique hospice agency, but in general, they try to move people to BiPAP rather than a Trilogy, for example. But yes, if the BiPAP is important for your sleep and for your, probably energy and, you know, breathing comfort, etc., you can keep it.
Okay. One more here. It says, I may have missed it. Any pointers on choosing a facility? And I'm not
Oh,
sure if they mean for hospice or just to live in when you're in advanced
yeah.
stages of the disease. So,
Good question. Honestly, we struggle to find facilities that are really experienced caring for people with ALS. If anyone has suggestions, honestly, I'm all ears. If you've had a great experience somewhere, um, I'd love to know about it. But I think it's quite idiosyncratic. It's going to be based on your local environment. Exactly what facilities are there, exactly which experiences they've had with ALS previously. But often we find that they're not comfortable doing tube feeds or not comfortable doing non-invasive ventilation and not very experienced with ALS. So you definitely want to ask them those questions when you're evaluating a facility, whether it's a hospice facility or, a skilled nursing facility or an assisted living facility, etc.
great. Thank you. Well, that looks to be about it, which is great. We're just coming up on our hour as it is. Dr. Bischoff, thank you again for your time, for all of your information and wisdom, and for your commitment and ongoing work to build and feed into our expertise in palliative care and to improve the way we help people live with ALS and many other diseases that are such a challenge for people.
Well, thank
Um,
you so
so,
much for
mhm.
the opportunity to present tonight and for your interest. And I just wish everyone all the best with this illness. And I hope you're able to find the help and support that you need, whether it's with palliative care or otherwise.
Great. Thank you so much.
Thank you.
Okay, so with that,
Bye.
I want to thank everybody so much for joining us today. We are grateful to each of you for being a part of our community. And once again, a big thanks to all of our sponsors for their support. If you have other questions that were not answered today, including questions about the services offered at the ALS Network, please email us at askme@alsnetwork.org. The ALS Network brings our community together in various ways throughout the year to create help and hope for families impacted by ALS today and for those who will be diagnosed in the future. These celebratory and meaningful gatherings provide opportunities for connection and raise awareness and funds to benefit ALS Network's mission priorities. Please visit events.alsnetwork.org to learn how you can join us. Founded by Brooke Eby, who was diagnosed with ALS in 2022, ALS Together is a centralized hub for the ALS community to connect, share, and support each other on Slack. To join the community, go to alstogether.org. As you know, philanthropy fuels everything we do, and we are grateful to the generous donors who make gifts of all sizes throughout the year, including contributions through an estate plan. To learn more about how you can support valuable programs like this one, please visit our website at give.alsnetwork.org. And please watch for the short survey on today's presentation that you'll receive via email in order to help us plan for future programming. Thank you again, and we will see you next time.